First of all, I think you've already been hearing today that vein disease is an incurable disease. You're going to have recurrences, so whatever we do, it's really not to cure the disease, it's trying to minimize the recurrence or the recurrence-free interval, so to speak. So let's keep that in mind as we're talking about any of these different devices and or procedures. So we're talking about the clinical outcome, not how it affects the vein, not how it affects recurrence in terms of reflux, but we're talking about how it affects the patient. And at 1 week, perhaps the ablation method matters to the patients in terms of their quality of life. 1 month, maybe, but honestly, I think after that, you can kind of make the argument it really doesn't matter. And I'm going to kind of take you through some of that thinking. So closure rates. We were all so focused on closure rates until the last 5 or 6 years. It was all about, you know, does the device work? Does the method work? Does it close the vein? We didn't look that much at how it affected the patients. So early on, we were more interested when we started doing ablations in the late 90s and the early 2000s about what was going on with the vein itself. Now we are looking at the patient. Remember, we're treating people. We're not treating their veins only. We have a lot of measurement tools to look at how things are either improved or not improved in terms of how it affects the patient. And we really have to talk about what our primary and secondary endpoints were. And as I said, in the early start of endovenous ablation, it was really looking, the primary endpoint was occlusion and or recurrence rates. Later on now, recently, we're looking at the quality of life measures. And now really the primary endpoint needs to be the quality of life measures. And the secondary endpoint is the occlusion. And it's not just for us. It's also for for government who's paying for these procedures. Private insurers who pay for these procedures. They want to see how it affects the patient's quality of life and does it improve their quality of life. We have a lot of choices. The newer choices are in the red. More older choices are in the white. There's 2 categories that have been alluded to, and about a year or so ago, I wrote this article dividing the endovenous ablation into thermal tumescent and non-thermal non-tumescent technologies. So the thermal tumescents are listed here, and the non-thermal non-tumescents are mechanical occlusion chemically assisted. A lot of these were in the workshops this morning. The cyanoacrylate adhesive or glue, foam, and V-block. We all talk about this great meta-analysis by Renato van der Bos, who told us, review the literature really up to 2007. A lot of limbs were studied, but in my mind, it really didn't include many of the procedures that were done in what I call the modern era of endovenous ablation, or MIVA, once we got over the global learning curve. These papers almost all address occlusion rates and not so much quality of life. And it's good. It's a good paper. It lets you know where we were with the technologies back before 2007. But honestly, we want to know where we are now and how things have affected quality of life. And this is a very good study by Lars Rasmussen, which has now been carried out for longer than a year. It's gone up to 3 years or so now. Still, the results are the same. He compared laser radiofrequency, foam, and stripping, but he was really looking at how it affected the patient. And what he found, they had 500 consecutive patients, that things seemed to work, okay? And patients were looked at right after surgery and then at different time intervals. I want to bring you to the attention that many phlebectomies were performed on many of these patients in all of these types of endovenous ablations. And I'm going to kind of sum up at the end that I think the actual fact that the phlebectomies were performed may be the thing that really kind of equalizes everything out and why everybody wound up the same after a number of years. So they measured some disease-specific quality of life forms. Yes, radiofrequency and foam in the short term performed better, but really in the long term, all these treatments were efficacious. There was technical failure rate highest with the foam, but again, results in long term in terms of how it affected the patient's quality of life were all basically the same. So it's not the closure rates, it's looking about quality of life. This is a study from the polydocanal endovenous microfoam, or Varithena is the trade name, and what they looked at was 235 patients, but their primary endpoint was patient-reported outcomes, or a new quality of life measurement called the VV-SYMQ, or Varicose Vein Symptomatic Questionnaire. It was approved by the FDA, which came up, they wanted new quality of life measurements. They were not so interested in closure rates. They wanted quality of life. So this was the primary endpoint. Secondary endpoint was what the patient said, how do my veins look? and how independent physicians said, how did the veins look? The tertiary endpoint of this study was closure. That was really regarded as a surrogate endpoint. So take away here that that's what we're trying to look at now is the how it affects the patients more than anything else. And you would expect patients got better. Okay? The VV-SIMQ went down by a significant amount, and the doctors and the patients thought the varicose veins improved by a significant amount also. This is now moving to another ablation method called mechanical occlusion, chemically assisted. This is looking at 50 patients with small saphenous occlusion, incompetence, 94% occlusion at 1 year. More important, the venous clinical severity score improved. This is a study comparing MOCA to radiofrequency ablation. And yes, people maybe got back to work, had less pain with the mechanical method, but the quality of life measurements were also equal. This is data from the 5 years closure fast follow-up studies. And again, you can see that at the baseline, SEEP scores were C2, 3, 4, and at 5 years, the SEEP scores held that they improved and remained improved. Here again, looking at quality of life, or VCSS, went down after 6 weeks, and after that, stays the same. I purposely left out what each of these curves are, either for radiofrequency or this is from the recovery trial, laser versus radiofrequency. Yes, you can see in a very short time, this is just a matter of a few weeks or so, things were different, and this is obviously laser, this is the radiofrequency, but when you got to 30 days, everybody's about the same. Same thing here, when you got to 30 days, VCSS was about the same. In terms of the civic scores, again, better is, higher is better. They all equalize at around 30 days. This now is a glue study. Again, at 24 months, the VCSS was improved. Okay, this is the European trial showing for glue as well. VCSS improved again. Once again here, comparing glue to radiofrequency. At day 3, everybody is kind of about the same. This is significant bruising. This was minimal bruising. A little bit better for the radiofrequency, but at 6 months, look at these curves. Everything in VCSS is exactly the same. Again, this is exactly the same. Okay? What I want to bring attention to is a non-ablative technique, which is removal of varicosities and sparing the saphenous vein, the asphalt technique, which I'm sure many of you are familiar with. This is a 4-year follow-up from Paul Pitaluga. Symptoms improved, no recurrence at 4 years in 88% of the people, and reflux remained improved once you took care of the varicosities. As Nikos told you, some varicose saphenous veins do not need to be ablated. In a retrospective analysis, again, they showed symptomatic improvement at 4 years and freedom from varicosities at 4 years as well. But this, I think, speaks to the fact of that removing the visible varicosities also helps to kind of equalize everybody out as well. It's not just the ablative technique, but it's taking care of the varicosities as well. In terms of endovenous dermal ablation, because of all the data that I've just showed you, the SVS, American Venous Forum Guidelines, give ablation a grade 1B recommendation as the treatment for the saphenous, and because it's shorter convalescence and less pain and morbidity, they recommend it over open surgery. Also in ulcer healing, similarly, same idea, again, because of the data that I showed you. They're not saying which technique, they're saying endovenous ablation techniques. In terms of the British, in terms of the NICE guidelines, they recommend ablation first, then sclerotherapy, then surgery, and stockings last. And this is obviously based upon multiple trials that they looked at before they came up with their policy. Again, each ablation method seems to work as well. I think the great majority of times there may be unique situations when one type of thermal tumescent is better than a non-thermal non-tumescent. But in general, if you're looking at how it's going to affect the patient's quality of life, I'm not so sure it matters. 1 week perhaps, less pain with some of them. 1 month maybe, but 1 to 5 years, I don't think it really matters. And we may get down to not necessarily what works best, so to speak, but if they all work the same, perhaps the least expensive method may wind up being the best. So don't worry, be happy, vein disease is good.